Everyone, my name is Diane Fabi King, and I am a Senior Public Health Advisor in the National Health Service Corps under the Bureau of Health Workforce. It's my pleasure to welcome you to our webinar today entitled Leading During a Public Health Crisis, Part 1. So welcome, we're glad to have you. Our readiness series is an intentional step that the National Health Service Corps has taken to assist our NHSC members in becoming culturally competent clinicians through
and Adjunct Professor of Nutrition and Integrative Physiology at the University of Utah. She has nationally recognized expertise in professional well-being, innovative curriculum design, and transformative clinical programs to address lifestyle and preventive medicine. Her research, education, and clinical roles focus on helping people lead healthier lives through a focus on whole person health. She serves as chair of the board of the Academic Consortium for Integrative Medicine and Health and is adjunct faculty at the University of Michigan. So today's webinar is the first in our mini-series on leading during a public health crisis. In the previous mini-series, we focused on the structures and practices NHSC-approved sites can implement broadly to foster organizational resilience and reduce clinician burnout. In this current webinar series, we really want to narrow in on the key skills needed for leadership staff to successfully navigate public health emergencies and support clinician well-being. Amy will cover these core competencies and will also share her experiences leading the COVID resiliency work group at the University of Utah. We're really lucky to have her today. The next two webinars will focus on protecting clinician mental health and measuring burnout among your clinicians. Please join us for those webinars as well. You might see on the right side of your screen a poll. It's called Slido, and we'd love to see who's in the room today. So if you could go ahead and fill out that poll about what your role is related to the National Health Service Corps. I will do a little bit of housekeeping before I hand the mic to Amy to get us started. So this webinar is being recorded, and a link to the recording will be emailed to you within 2 days. The PowerPoint slides can be found on the webinar registration page, which we will link to in the chat now. Related documents and previously recorded webinars in the mini-series are all available on the webinar registration page. This is a 1-hour webinar. We will have time for Q&A at the end of the presentation, so please type questions you have for the presenter in the chat box on the right side of your screen. You may have to manually open that chat box by clicking on the chat icon in the bottom right corner. There will be opportunities to engage with Amy and other participants during the presentation through polling, the chat box, and by raising your hand to speak. If you have technical assistance questions, please contact our colleague Josh. His contact info is being pasted in the chat now. Finally, we would also appreciate your feedback on today's session. So please complete our survey at the end of the webinar to let us know how we did and how we can improve our trainings. To see closed captions, click on the CC icon in the bottom left corner of the webinar window. And finally, I'll hand the mic over to Amy now to begin our presentation. Thanks, Amy.
Thanks, Molly. So it's really nice to be here today. I'm really excited to chat with you all. Although I don't have any personal experience with National Health Services Corps, I do have experience with both rural and urban marginalized communities as a part of my clinical work as a family physician, and really think that the work that all of you do is incredibly important. And so, Molly, if you could just advance the slide 1, that'd be great. Oh, actually, I can do that. That's right. Sorry, I forgot.
Yeah. Okay.
Yes, sorry,
Great.
I forgot.
Okay.
WebEx is magical and allows all kinds of fancy things that I'm not used to. So thanks. So today, as Molly mentioned, there are accompanying presentations on protecting clinician mental health and on measuring burnout. And the focus of today's presentation is really on leadership skills. And so we're going to talk through some competencies for responding to public health crises. And then we're going to talk a little bit about some of the actions that can be taken to both plan for and respond to a crisis. And we'll use University of Utah, where I am, as an example of how that looked during COVID. And so when we think about the role of leadership in a public health crises, obviously all of us have become way more familiar with this than we would have been 4 years ago. And while this crisis has largely passed us by, we have a real opportunity to consider the skills that could prepare us to manage future crises, both small and large. And what we know is that the healthcare workforce really depends on its leadership to guide them safely through a public health crisis. And leaders that are effective, they do some pretty predictable things from site to site, from hospitals to public health to small clinics to big systems. They effectively inspire their workforce. They foster a culture that is a culture of support and well-being. They are very good at providing consistent and open feedback, and they are able to improve and adapt systems to support new and changing needs, with really trying to minimize the barriers to the workforce so that they can do the hard work that needs to be done. And so we're going to be digging into this a little bit over the next few minutes. And so this study that we are going to talk through today really looks at a literature review on leadership competencies in public health crises over 2 decades. So this includes COVID, but also includes Ebola, influenza, the SARS epidemic a few years ago. And what they found is that leaders really work at the intersection of competencies that can be divided into 3 categories. So task competencies, people competencies, and adaptive competencies. And that there are influencing and contextual factors that impact each of these 3 buckets. So we are going to spend a little time digging into each of these categories today. So when we think about task competencies, you're like, well, what does that mean? That's really focusing on the knowledge, skills, and behaviors that are required to manage the pandemic response. So, for example, during a public health crisis, leaders are called on to perform a variety of tasks, and preparing and planning can range from identifying a crisis early enough to develop emergency preparedness protocols, managing implementation of those protocols, allocating resources, monitoring the crisis, and really developing contingency plans. And so when we think about that, communication and collaboration are really essential pieces to that. So for example, in the pre-crisis phase, effective communication really allows formation of those functional partnerships and allows us to engage in that collaboration that's so important. During the crisis, effective communication allows us to engage in others who are preparing risk responses, sharing emergency communication, both externally with the public and internally with the organization, and allows the group to communicate a clear vision in a shared sense of purpose. Now, obviously, as many of you have experienced in the last few years, those public-facing leaders get a lot of pushback, some of that really positive feedback, some of it really negative feedback. And this is a time when communication skills related to media communication are really an essential capacity, and having experts who have experience with that can be extremely helpful. When it comes to collaboration, a leader's ability to build collaboration really emerged as an instrumental competency. So it's really essential to effectively coordinating the response and being efficient with our resources. In a crisis, leaders really need to be able to develop networks with other organizations and cultivate interpersonal relationships that are truly grounded in mutual trust and understanding. These three task competencies are, of course, all interrelated to one another. So, for example, communication and or collaboration are very important to be able to effectively plan and really build off one another for efficacy. So when we look at the people competencies, what we're looking at here is skills and behaviors that really focus on interpersonal relationships that are necessary in order to be effective. So a leader's ability to engage others was really essential in the studies that were reviewed as a part of this paper, and specifically requiring attributes such as empathy, awareness, being physically and emotionally present for teams, and of course, caring about the well-being of self and others, and really this ability to inspire teams. So, for example, leaders who are able to empathize with team members, respect others' values, and demonstrate an inclusive approach, were able to build those relationships, increase trust and improve morale, decrease occupational stress, and increase engagement for the teams and others. And while all of that is, of course, essential to being effective in a crisis, it's also essential for doing the work of the organization when you're not in a crisis. And so I think this is an example of some of those things that we perhaps learned during COVID that we can carry forward into the future, regardless of whether or not we're in a crisis state. Okay, hit the right button here. So we talked about adaptive competencies. So adaptive competencies really focus on the skills and behaviors required to respond to the dynamic nature of a pandemic response. So I know anyone who works in healthcare knows that there is a lot of change that happens in healthcare. Science is changing, the way we do things is changing, technology is changing, but during a public health emergency or a crisis, things are changing at an astronomically accelerated rate. And so a leader's ability to rapidly adapt to the changing context is really essential in successful crisis leadership. And so, for example, during COVID, leaders were often called on to make really critical decisions with very little evidence or rapidly evolving evidence. And so that adaptability was essential to the success of an organization. So again, contextual factors. So contextual factors really fall in this evaluation into three categories. And they really shape how leadership competencies are demonstrated. So structural factors might include things like hierarchy, the presence or absence of team cohesiveness, resource allocation. Cultural factors are fairly self-explanatory, but for example, in a complex structure with really centralized control, decision-making and planning becomes impacted. And then, of course, political factors also can play a substantial role. Things like power dynamics among different agencies, the amount of trust or lack of trust can play a critical factor. So what are the actionable steps? So this is really, when I think about what gets me excited about this work, really thinking about taking this work and putting it into actionable steps is the most important thing that we can do. If I think about the last 10 years that I've been really thinking about burnout and about well-being, and all of the groups and individuals and teams and leaders that I've met over that time, The vast majority of them feel overwhelmed by the concept of addressing professional well-being. So not necessarily just personal well-being, like do I eat healthy and do I take care of myself, but how do I show up as a person at work? And what is my well-being in the workplace? And so that's really where being able to talk about, well, what are the actionable things that I as an individual could do? And that might be an individual as a medical assistant in a clinic. It might be me as a leader at an organization. That trying to find that locus of control and creating an opportunity for agency is really what it's all about. And so I typically break that down into three kind of buckets. So if I think about my own institution, the work that we're doing today, that we've been doing over the last 7 or 8 years, most of it fits into one of three buckets. The first is, as you see here on this slide, understanding where the organization is at. So getting data and using that data to change what we do. That allows people to have that locus of control and to have that agency and to be able to sort. So what can I do? What can you do? What can we do to make this place a better place to work and to make us more effective at whatever it is that we are trying to do together? So for example, for many of the people on this call, it will be to provide healthcare to a highly vulnerable population with often limited resources. The second piece of this is incredibly important, and it's building out a community and a culture of well-being. And so that's where resiliency training often comes in. And then the third is really thinking about occupational trauma is something that happens to us in healthcare on a daily basis. So being able to recognize that and having a population health response to be able to match the resources to the individual at the level of care that they need. Something we think about with patients all the time, but how do we turn that on ourselves and think about, well, what do each of our people need? So as I think about those buckets of get data and figure out how to use it, build a community and a culture, and provide people care when they need it because they've experienced trauma at work, a lot of that conversation that is generated is really about listening and talking to people in a group to really understand what matters to you. So if we think about a patient in front of us, let's say they have diabetes or they have heart disease, and we're trying to help them meet their health goals, a common question might be to that patient, what matters to you? Why is this important? What do you want your health for? And that same approach is very helpful when it comes to the workplace of you show up at work, you could work anywhere, you work here. What matters to you in this space? Why do you show up every day? How could we make this a better place? And what drives either burnout on one end of the spectrum or thriving in work or joy in work on the other end of the spectrum? Okay, so when we think about preparing for a crisis, it is really important to get an understanding of where people are at in the organization. And then I would argue that the tool itself is not as important as what you're going to do with it. So I have seen organizations all over the country arguing about, oh, we're going to do MASLAC, oh, we're going to do ProQual, oh, we're going to do Mini-Z, oh, we're going to do our own, Stanford Wellbeing Survey or Mayo Wellbeing Survey, or we're going to add some questions to an engagement survey that already happens. And while we could sit here and debate that all day about which one is better, I would say more importantly is how do you use these tools to get some data back that allow you to have those what matters to you conversations on the other side. And so being able to share the assessment findings and engage in those conversations are really the critical pieces that we want to do. Okay. And I guess I would say that there are 50 reasons why someone might be burnt out. So if you don't get any information about what's driving that burnout, it's really hard to intervene. So for example, someone might be burnt out because they personally are overtaxed with their home life. and they are showing up to work already stressed out, or they have occupational trauma that they haven't dealt with, or they might be showing up to a culture that really is not supportive, a culture where people don't feel comfortable talking about stress and the experience of working in healthcare. Or they might show up to a workplace that's asking them to pack 80 hours of work into a 40-hour or 50-hour work week. And so knowing what those drivers are within a unit or a clinic really allows us to then do the hard work of actually improving this scenario. Okay. So I want to spend a little bit of time talking about culture. So resiliency training in some ways is a no-brainer. Like helping people understand stress and how that impacts well-being and how physical health and emotional health interplay off one another is super important. And at the same time, resiliency training can be controversial because it implies, potentially, that if we just provide resiliency training, working in healthcare will be fine. And of course, if you ask the average person that is burnt out, they would, of course, have lots of comments about why they're burnt out. And it probably wouldn't revolve around whether or not they have been trained with resiliency training. And so the messaging of this work is incredibly important, because if you just show up and say, hey, burnout's a problem, we're here for you, we're going to provide this resiliency training, and without some messaging around why people are burnt out in the first place, it really can make it much harder to impact. The other thing is that training programs need to be delivered in the context of a population health model. Everyone might benefit from a resiliency training, but some people are actually going to need a really much more intensive and targeted intervention. And so having a plan about what do you provide to everybody, and then what do you provide to those people who might have had an adverse event or something that they just went through that was really traumatic, and then what are you going to provide for people who are really struggling and need to see a one-on-one mental health provider. And so there are lots of different resources out there. And Molly, I think I sent you a couple that if you could pop those into the chat, that would be great, that I've used before. One is one that we've created internally, which is a toolkit that people can use as a train-the-trainer model. The other's from the VA. But ideally, training programs would target clinician self-care, would really normalize the anticipated psychological responses to crisis, and then would promote adaptive responses and self-efficacy. And the vast majority of programs are a great way to normalize stress happens. Occupational trauma is a thing in healthcare, and allow, again, on that culture piece, the conversation. So when I think about the culture of an organization and the role that resiliency training can take place, I think of three things. So one is culture is about community, like, do I know your name? Do I know if you have kids or not, or if you have a dog, or what you're going to do on the weekend? Do we see each other as a unit that's doing work together? But the second piece of culture is where that resiliency training really fits in, which is that we need our own health to be effective in providing care for other people. We need to be able to talk about vulnerability and stigma, physical and psychological safety, that those resiliency courses can really help give us a vocabulary and a language and some skills to be able to support one another the way we would theoretically and hopefully support our patients. And then the third thing that culture really does for us is that it helps us develop agency, so that we show up in the workplace with a sense that when we see things that aren't working well, that we actually can have some impact on making this a better place to work. And if we're able to do that effectively, we will dramatically decrease turnover, and the satisfaction will go up in our ability to come to work and feel like we're making a difference. And I think one of the biggest things that I've seen in the resiliency trainings that I've participated in is just some language around what is moral distress. So when we show up in the workplace and we're asked to do something that really goes against what we think is the right thing to do. So for example, I'm a family physician. If I show up in a room with a patient who is experiencing homelessness and doesn't have food, and I have 15 minutes, and I'm also supposed to address their heart failure and their diabetes that's totally out of control, and I've got a huge stack of patients extending on into the afternoon, I will be stressed. Like, I will find that to be incredibly distressing, because the person whom I'm supposed to be their physician, I won't be able to provide that care that I feel like that person needs and potentially deserves. And so when we can recognize that moral distress and talk about it and share those experiences and really use that agency to change the things that we can, we see a real improvement in burnout and again, building that community. Okay, so this is a good opportunity to go to Slido here for a minute and just to pause and reflect. How has your organization measured burnout? And or if you have thoughts, what programming have you seen implemented to address burnout? And I might encourage you just to be thinking about, and if you want to type this in as well, is where have you seen this fail? So I will share one to kick us off. There is an organization in the vicinity, not at my own organization, where their solution was to put a required training module, resiliency training, as a required deck that you had to go through as a part of your annual like fire safety, HIPAA training kinds of things. And I would say that while the content was good, the like required nature of it really, really fell flat. So I am going to type something in here so that I can see what you all are putting in.
Amy, this is Molly. I'll just let folks know if you're not aware, a Slido survey should pop up on the right side of your screen. And there's 2 questions there. If you cannot see Slido, you could type in your answers in the chat. And if anyone would like to come off mute, just raise your hand at the bottom right of the screen. There's a little hand icon, and we'll send you a request to unmute, and we can have some interaction with Amy.
And, you know, what I will say is that most organizations go through a real process. So if I think about the first time we measured burnout specifically at the University of Utah was in 2016. And we started with the mini Z. And I went to Stanford, I went to Mayo, I looked at the Maslow burnout inventory, we looked at the ProQual, and just thinking about, okay, well, these are all of our choices. And we ended up choosing the mini Z, and then we added some questions on stress and some other things that we thought were important. And it was a pretty good survey, I thought. But again, that response to the survey wasn't as well orchestrated as I would have liked, because when we showed up with our data and we're all there, we're ready to share. And then it turned out that human resources also had a survey, and they were kind of making the rounds. And then the medical group, they also had a survey. And in fact, the EDI group, they also had a climate survey. And so we were all independently going to groups and saying, hey, let's review your data, let's make an action plan. And that discoordinated response meant that nobody had great response rates to their surveys. And people were confused about, well, should I look at this data or should I look at that data? Do I make planning with you? Is that the same planning I make with this other group? And so fast forward to 2023, for the first time in our organization this year, we will have a unified survey that all of those groups have contributed questions to, and that we will make action planning with groups together. And so I anticipate, my fingers are crossed, that that will be far more effective than each of us trying to do a planning with each group by themselves. Okay, not a very chatty group today. I don't think we have any other comments in Slido. So I am going to move on to the next slide. And if you have questions as we go, feel free to drop them in the chat. Okay, so next what we're going to talk about is just a couple of very specific strategies that have quite a strong evidence base of ways to impact well-being. And so before, what I was talking about is kind of really big conceptual frameworks of how do we think about this, but now we're going to like brass tacks, what do we do? So one of the techniques that has been very, very important is contemplating workload. So if you ask the average clinician, what is driving burnout for you or lack of burnout, 9 times out of 10, they will talk about workload. So kind of toxic work environments are another hot topic, but I would say workload shows up number one almost always, because healthcare is hard and there's a lot of work, and there's a lot of work that doesn't feel very important. So we have to chart long charts, we have to click lots of boxes, we have to communicate potentially with things that are not really things we have expertise about. When was my last vaccine on tetanus? Well, you don't really need a physician for that. But in a medical assistant might be overtaxed in other ways. A nurse might be overtaxed in other ways. And so getting rid of stupid stuff, or GROSS, which is of course a great acronym, is a really fantastic opportunity to try to look at how efficient are we at getting our work done and what is the workload. So again, we have kind of created systems at this point where people don't often have time to think. They're fairly isolated, despite the fact they're often in a building with a lot of other people. And a sense of, I just need to work harder. If I just go faster, then everything will be okay. But anything that can help identify administrative burden and reduce that can be fantastic, and really shouldn't wait until there is a crisis response. So if I think about examples of this, one that comes to mind from this week. So I want to order a fecal immunochemistry test. Well, I type in that order and it pops up and it says, what's the sample? Now, for those of you who don't enter orders, you might think, well, I don't know what that means. But basically it says, like, where is this sample coming from? Now, this is a stool test. So really the only choice is stool. But I have to select that from a drop-down menu of 1 in order to sign that order. And so, of course, that's annoying. Not very long, right? It took an extra 1 second. But as those things accumulate over time, now, of course, that wasn't really intentional. Someone just didn't, when they designed the system, make it so that it defaulted to stool. But in my own organization, thankfully, we have a group of provider informaticists and a whole IT group that sorts through those topics and eliminates them as fast as they can. So that those really not important kind of things that slow you down, that someone is culling through those and pulling them out bit by bit. Okay, so what's another example? So another example is scribes. Now, I find this fascinating because medical scribes, some people call them documentations assistants, they're basically people that type or that document into the electronic medical record what is happening in the encounter. What we know with pretty much every study that I've ever seen about scribes is that clinicians love them, patients get better one-on-one, I'm sitting here talking to you as a visit rather than tell me a little bit more about what's going on, hanging out with my computer, that it improves teamwork, that it pays for itself, that people are burnt out less. Now, here's the thing that I think warrants some conversation. Why don't we all have scribes? If it's so great and the data is so great, and I once had a scribe, it's been many years ago now, it was wonderful, loved it. My notes were actually kind of terrible, but patients got great care. And when I reflect on why doesn't everybody have a scribe right now, I think that a lot of it has to do with turnover. So being a scribe is kind of boring. We're all short-staffed for all sorts of other things. Nobody has enough MAs or other administrative professionals. We have problems with true cost allocation. So when we save money over here, it doesn't always show up on the balance sheet in an organized way. And I think sometimes clinicians are their own worst enemy, that we want this note to be this perfect thing that is written just like I would talk. And that, of course, it's really hard to find a scribe who will do that. I will say that my prediction is that in the next 5 years, we have AI doing all scribing for visits. And I think that is going to be amazing. In the meantime, for those of you who don't have scribes, the best evidence would suggest a shared documentation with a medical assistant, so that you would increase the number of medical assistants. In my office, we've started using EMT trained people as a way to get more, to expand the applicant pool. We see a great number of people who want to someday become a physician's assistant or a nurse practitioner or a physician. So that's a great experience. And ideally, that person would take your notes and be the person who roomed the patient, so that then it's not like you're introducing yet another person into the visit from a space perspective and a personnel perspective. Okay, so again, this is an opportunity for us to pause and reflect, just thinking about how has your organization successfully decreased administrative burden. So if we want to go back to Slido, what's one thing that you've seen be effective in this space?
The voting was locked for a few seconds, but it's unlocked now and folks can type in their answers.
So while you're thinking about potentially putting something in, I will say that one of the things that's been phenomenal in my own office is that our pharmacy team has been doing our prior authorization work for us. And because they do a lot of it, they're very quick at helping patients through the prior auth process. But a lot of this administrative burden needs to be sorted. So again, kind of coming back to that sorting process of like, there's things that I as a personal clinician can change about my workflow. There's things that my clinic can change about our workflow or administrative burden. And then there's things that the organization really has to address. And so one of the tools that the AMA, American Medical Association, has shared is this idea of listen, sort, empower, improve. And so listen, sort, empower is using that quality improvement modality to really get on a whiteboard or on a piece of paper, like what are the things that really get for us in our small group in our way? And then how do we sort impact and feasibility? And then really think about what we as a group have a locus of control over that we could do some iterative improvements. So thank you, Ronald, for sharing this improved efficiency of the EHR and really making sure people are working at the top of their license. And that's really essential. Now that's easy to say and hard to do potentially. And so there often is this iterative, okay, let's try this. Okay, well that worked or didn't work. Okay, let's try this slightly differently. Okay, so moving on. So one of the things that was really essential in the pandemic that is not super relevant at other times is like looking for people who can come and work for us. So, you know, for me as a person who really in recent years has only done ambulatory care, thinking about like, yeah, maybe I would show up in a hospital or even in ICU. Of course, we're not going to do that on a regular basis, but there are some lessons learned from pandemics that carry forward even into regular times. And I want to talk through a couple of these today, because being able to be flexible with work hours is really important. So what we know is that people who are getting burnt out, often before they leave their job, they start talking about, I just need to cut back my hours. If I could just go to 80% time, then things would be great. And so really trying to make sure that we are staying alert to that. And so when someone says, hey, I just want to cut back my hours without a lot of like explanation, to really start to get into the weeds of like, hey, are you doing okay? And of course, being as flexible as possible when we can. So, you know, when can we provide telework options? Can we think about job sharing? Can we allow people to work part-time? You know, I will say for myself, as a parent, when my kids were little, having the opportunity to decrease my FTE temporarily while they were small was immensely helpful. And then now, you know, I'm back to working full time and my kids are older, and professionally, being at an organization that allowed that, at the time I was at the University of Michigan, it was amazing to have that opportunity. And it kept me from burning out, and kept me engaged in the work. Otherwise, possible I would have left that organization, or potentially even have changed professions. Okay, so we have another opportunity to go back to our Slido to just think about, like, well, what has worked for your organization in terms of increasing staffing, and what barriers have you run into? And as we're pulling up Slido, I've shared a couple already. One is thinking about, like, do you really need to have, for example, a medical assistant training to do the work of a medical assistant? So, for example, we hired EMTs as MAs. Another thing that we have been working on in recent years is a medical secretary. So what's the work that really doesn't even require any kind of medical training in terms of scheduling or kind of more administrative responses to requests that come in, records, etc. Okay, so I'm going to take us on so we can save some time at the end for questions. So another thing that, of course, is really important in a crisis is that leaders really need to send clear messages that clinicians are valued. And one way to do that is to provide proper protection from exposure, and really working to try to limit the risk of coming to work. Now, of course, this was so important in 2020. These days, I think we've kind of figured it out. But the next crisis that comes along might have really different needs. And so, right now we're really still, for COVID, we're thinking about aerosol contamination, but, in a different pandemic, it might be something else. And so it is important to kind of keep this in the back of our mind. And, I think what's really, I think, been helpful from my perspective as we come out of COVID and we stop wearing masks everywhere is being able to kind of quickly return to that when someone's ill. And as many of you know, there are lots of different ways in which you can think about limiting exposure. And so sometimes that can look like things we actually engineer into the way we do work. Some are administrative. And of course, just being aware of safe work practices. In terms of other things to consider, the things that are here on this slide from Dewey, one of the bright spots of COVID is that culturally within the United States, we became much more comfortable about talking about stress and really thinking, again, I mentioned this earlier, about how physical health and psychological health are tightly intertwined, and that when we are stressed out psychologically about something, we often really experience physical symptoms. And just that simple concept has really opened the door with patients. So much easier to talk about this topic with patients. But with clinicians and healthcare providers, it's also much more comfortable to have some of these conversations. And so we've really opened the door to developing networks for supporting both mental health of patients and clinicians. It's really opened up the door to talking about social determinants of health, not only with our patients, but also with our employees, and really has allowed us a little bit of space to talk about, like, how we respond to moral distress and what we need to do in the workplace to make that possible. And so I would just invite you to enter into the Slido what other strategies you've seen your organization use to improve resilience. And I'll share one that I just talked to our College of Nursing faculty yesterday, and they kind of were switching sick days in their colloquial conversation to health days as a way to really talk about both physical health and emotional health. Like, you don't need to have some like terrible infection to not come to work or to take a day off. That mental health is really also an important reason to potentially stay home. Okay, so experts really point to a collection of executive tasks that are found in high-functioning teams. And these groups in this study really had, again, a consistent set of skills that made them very effective as leaders. And so they had high levels of experience collectively going in. They had a strong culture. So those teams that were most successful, they had a really strong culture where they could be open and make decisions together. They had the ability to self-organize. And they had the ability to learn from the process as they went. Flexibility and rapid adaptability. And so again, if we look at those teams that have done well and we take those bright spots, then we can try to teach those skills and employ those skills in other settings. Are we on time? Okay. So, so thinking about meeting and communication. So when organizations are hit by a crisis, staff often look to leadership to hear how they interpret the situation and what they plan to do to restore a state of normalcy. And so leaders are then really expected to provide this idea of authentic hope and confidence. Clear and transparent communication may give rise to interpretations that are less supportive of the ongoing crisis management efforts. And botched communications can have severe repercussions. And so leaders really have this opportunity to explain the crisis and its consequences, with also providing very actionable advice. And again, we talked about this a little bit earlier, but there's really a difference between kind of routine communications and the skills that are needed for crisis communications. So looking to the literature on crisis communications and experts who like that is their job, is crisis communication, can be really helpful in deciding how to communicate, what to communicate, how often to communicate, and what we are able to intervene with and what we can't. And so that opportunity to say, I hear you, that you see, you're seen, you're heard, you're valued, we hear your feedback, and these are the things we can't do anything about, is really, really essential. Okay, so moving on. We're going to skip over this Slido and just share a couple of cases. And then I want to spend some time talking about our work at the University of Utah. So we have this case here from Annapolis where they really dug into, do you need to be in the office? Or could you work from home? And they found that by pulling those administrative tasks during COVID and putting them at home, and keeping some people in the office to do the things that absolutely have to happen in the office, really allowed them to improve the experience of their employees and also actually improve their sick leave because it allowed decreased gaps in office coverage. The second case I want to share with you is this group in Chicago. And what they did is they said, okay, we really would like our people to spend a little bit of time being able to focus on grants. And so they allowed folks to pull out a little bit of time to work on a project. And so what's magical about this is they've taken this literature that says that people who have their own time to work on something that brings them meaning and purpose have less burnout in their job. And so what was exciting about this project is it actually allowed them not only to reduce their burnout by allowing people to work on passion projects, but it also allowed them to meet all of their quality measures through this work and partnership with a local school of public health. So it's a great example of a win-win. Okay, so what did we do during COVID? So at the University of Utah, we've been working on well-being work in a coordinated way since about 2016. And when COVID hit in March of 2020, we very quickly pulled together a leadership group of experts in well-being, patient experience, human resources, clinical units, and we developed some sponsors on the senior leadership team. And we said, okay, this is how we're going to quickly think about what does the organization need, what do individuals need, and to try to like run that as fast as possible. And so what I'll say is that the resiliency work group, the kind of core 5 of us, are still meeting once a week, all these years later. And it has been an immensely productive way to kind of hear what's going on in the organization from different voices, from people with different backgrounds. And so at the time, back at the very beginning, the resiliency work group focused on 4 different subcommittees. We had a group working on basic needs. We had a group working on support services, so kind of crisis response. We had a group on recognition, and we had a group on communication. And these 4 groups were kind of running in parallel. Kind of the master group was meeting once a week, but these groups were kind of meeting on their own and rapidly, iteratively working on projects. And so if I think about the basic needs group, which I was the chair of the basic needs group, we're just like running the list every week. What are we hearing that frontline people need? We had a virtual suggestion box, but we also did a lot of boots on the ground, kind of like talking with teams. What are the things you need? And in March of 2020, it was like childcare, food, masks. And so trying to get each of those like became their own thing. So we had a whole mask group, PPE group. They're just running with that. The childcare group went on for years, and eventually we ended up hiring somebody university-wide to help with childcare. And we continue to think about food insecurity, not only with our patients, but also with our employees. The support group no longer meets, but a version of this work continues on to this day, like a 3-tiered occupational trauma response, so that there are always things for low-risk people, rising risk, and high risk. And we continue to work with each of the people on this list of folks in this space to this day. This work is largely coordinated through the Resiliency Center, which is where our well-being folks are housed. And then in terms of other groups, we really were able to understand what do frontline folks really need. And so, for example, we started out with this Heroes Work Here campaign, and it became clear fairly quickly that frontline workers didn't really feel like being a hero was necessarily in line with messaging around self-care and boundaries. And, eventually people didn't really want to be a hero. They just wanted to go to work and do their job. And so we changed all of our messaging. And I will say one other thing about the support group is that, during those early months of COVID, our support services increased by about 30%. And our one-on-one resiliency consult rates increased by 80%. And so being able to have a whole team of people that were beyond our network or our internal employees really allowed us to scale up to that need in a way that we wouldn't have otherwise been able to do. Okay, well, the last group was the communication group. And again, to this day, we are continuing to use these same ideas about how do we get people the information that they need at the time they need it, at the place they need it. And for those of you who are interested, Accelerate is Utah's online learning community. And one of the resiliency toolkit that we shared earlier in this presentation is a part of Accelerate. That is where we have housed the vast majority of our enduring material communications that we have shared with employees. And because that's open open access, it really makes it easy for other institutions to use some of those tools. Okay, so I would just, at this point, turn it back over to Molly to potentially run us through any questions or comments that folks might have. And
Thanks,
thank
Amy.
you so much
Oh.
for having me today. Sorry, go ahead.
Oh, no, thank you for joining us. It's so nice to hear your professional experience with the COVID resiliency work group. So since we only have about 3 minutes left until the hour, I will just see if there are any questions from folks in the chat. Let's see, there is one. Could you speak more to moral injury, Amy, and how we can address it in our agencies?
Yeah, that's a great question. And if I think about, I've been thinking about like our medical group. Like, what can the medical group do? I think that workload and staffing is largely at the root cause of moral distress. That people feel alone, they feel like they're a cog in the wheel, they're valued only for their ability to make money for the organization, and that when we can change that narrative to start talking about moral distress, we can then intervene upstream before people are burnt out and they leave the organization. So if I look at my own organization, people are leaving. They feel frustrated, they feel like nobody hears me. If I look out over the organizations all over the United States, I see the same thing. People are like, I gotta get out of here. I gotta go find X. So they go to the new organization. Well, it turns out all the organizations are struggling in similar ways. And so the more we can have those conversations about moral distress and make it okay, like it's normal as a human for you to be distressed when this happens. Like that's how it works. Then we can start to do something about it. And sometimes there's nothing to do, right? So sometimes the patients want something that you will never give them. Like they want a giant narcotics prescription and they'd like some benzos to go with it and maybe a few muscle relaxants if you don't mind. Like you're not going to do that, right? But having a way to talk about it with the team and to process that emotion and that stress is really, really important.
Thanks, Amy. Unfortunately, we don't have any more time for Q&A. I want to make sure everyone can get out of here on time, but I'm so grateful for you being here today and you as well, Diane. And thanks again to tech support for helping us out. Before we close the webinar room, we are going to open the evaluation poll, and I will do that now. You should see it pop up on the right side of your screen. It's just a few quick questions, really helps us understand how you all felt about the presentation and how we can make improvements for the future. You should see it on the right side of your screen again. And yep, navigating to the reference slides now. If you're interested in gaining a better understanding of any of the topics covered today, please check them out. Amy and her colleagues did write an article about their experiences with the COVID resiliency work group. So that's the one starting with Morrow from 2021. So thank you all today for attending our webinar. And just a quick reminder that the PowerPoint slides and related documents are available to you on the webinar registration page linked in the chat. And we'll post that again in the chat for you. It's there now. The next webinar, Leading During a Public Health Crisis, Part 2, Protecting Clinician Mental Health, is Wednesday, June 14th at 2 p.m. Eastern. We encourage NHSC participants and leadership staff from the NHSC approved sites to attend. Please make sure you're registered and we hope to see you then. Thanks, everyone.
Thank you so much, Molly, and thank you all for coming to join us. We hope you come to the next series on June 14th. And thank you to our speaker.
Thanks.
Thank you, Diane. Amy, did you have any parting words for folks?
No, have a good afternoon.
Oh, thank you so much. We will leave the poll up just for about another minute so folks can answer questions, but thanks, everyone.